So this is the GI PCL, HM2 marker, HM2 cruise. We're going to be going through the PCL top to bottom. So like all PCLs, come in the room, introduce yourself, and do the V-team, your vitals, which should include your temperature, SpO2, blood pressure, yada, yada, yada. And then after that, tobacco, alcohol, allergies, meds. After that, you're going to go ahead and position the patient. Cruise is already in the position that you need to be. Legs relaxed, he's supine, and then the head should be elevated a little bit. These tables are kind of already set up for that. So first thing you're going to do is you're going to be inspecting the abdomen and the abdominal region. So you're going to be looking for surface characteristics, lesions, nodules, redness, ecchymosis, everything that goes along with basically the skin that's covering the abdomen. After that, you're going to go into the symmetry and contour of the abdomen, so you can actually have the patient raise their head a little bit, and it'll expose a lot of those abdominal muscles or any hidden hernias or masses or anything like that. Okay. There's three ways to describe the abdomen. It's either going to be distended, it's going to be concave, which would be like thin people, and then flat, which is your normal findings. So obviously flat abdomen, good to go. And then you're also going to observe the abdomen during the patient's respirations, making sure that it's good bilateral, you have good bilateral rise and fall. Males are more abdominal breathers, women are more costal breathers. After that, you're going to be looking for any surface peristalsis. This is more common with tall, thin individuals, so you shouldn't usually see that. And then also you're going to be looking for any aortic pulsations, which could be indicative of an abdominal aortic aneurysm. After that, you're going to move on to your auscultation. So I'm just going to kind of verbalize it, show you where you're going to need to place the stethoscope. So you want to do all the abdominal quadrants, okay? So you're going to go ahead and listen, and you're listening for bowel sounds. And you want to leave the stethoscope on the skin for, as soon as you hear a sound, usually 3 to 5 seconds is your normal sounds, but you're listening for those bowel sounds, and you're listening for anything like borborygmi, which would be like hyperactive, kind of gurgling bowel sounds. Absent bowel sounds, you need to leave the stethoscope on that quadrant for at least 5 minutes each. So 1, 5 minutes, 2, 5 minutes, yada, yada, yada. And then you can say absent bowel sounds. Then you also want to listen to the liver and the spleen for friction rubs. You can listen in the quadrants as well for that, and that would be a sign of like peritonitis, inflammation of the peritoneal area. Then you can also, after this, you can assess for venous hums and bruits. The listening posts for those are going to be different though. So right where the costal angle is, a little bit inferior to that, you're going to have the aortic. You're going to listen there. You can use the bell side, I don't have one, but there. And then you're going to do the renal areas. After that, it'll be the iliac. And then lastly, the femoral, which are going to be right here next to the apex of the pelvis. So those are your 7 listening posts: 2, 4 for the iliac, renal, and then finally aortic. Okay. After that, you're going to move on to your percussion of the abdomen. Really easy way to do it. You can either use the head of your stethoscope, or you can use your fingers, just like we did with respiratory. So again, percussing all 4 quadrants. So, and you're listening for that tympany in all the areas. Now you're going to have dullness over solid organs, and you're going to have tympany over hollow organs. Okay, so the next test that we're going to do is we're going to assess the liver span. So you start inferior to the costal margin here, and you work your way up, listening for that change from tympany to dullness. It should be mid-clavicular line, so pretty much right where his pocket is here. Hollow, 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 dull. Okay? So right here, you're going to make a mark. Then you're going to work down from that mid-clavicular line to find the top margin of the liver. Hollow, resonant, resonant, dull. Okay? So boom. So normal liver span should be about 6 to 12 centimeters. Okay? So you can actually measure it out. After that, you also want to percuss the other organs, so the spleen, and also when you're positioning yourself next to the patient, try and stay on the patient's right side. It just makes things easier. So the spleen is going to be over here. You're going to go between the 6th and 10th ribs, and you're kind of going to go in a spiral pattern. and you're going to be looking for dullness and resonance, and that's going to tell you kind of the borders of the spleen. So and then you're kind of just going to estimate the size of the liver or the spleen based off that. Next, you're going to do the gastric bubble. So that's going to be right around this area, in between the midclavicular line and the sternal line, basically. It's going to be right around this area, right at that costal margin. And then lastly, you're going to have the patient sit up. Go ahead and sit up for me. And you're just going to lightly percuss the kidneys, okay? So right below T12 and L3, you're just going to give a light tap. And you're just going to ask the patient if they feel any pain with that. Any pain with that?
No.
All right, great. All right, so that's all the way through percussion. Now you're going to move on to palpation. So you have to do light and deep palpation. So again, you're just going to be doing all 4 quadrants, one-handed for light, two-handed for deep. Okay, and you're just going to kind of go like this, and you're assessing for tenderness. You're looking for a nice, soft, smooth, non-tender surface. Okay, and you're going to be looking at the patient while you do this too. Any pain there? Okay. Any pain there? Okay. Any pain there? Okay. Okay. All right, cool. And then you can move on to deep. So just same thing, just looking at the patient, going a little bit deeper. Nothing? Nothing? Okay. And you're looking for that facial grimace. That's why you keep your eyes on the patient as well. And then you're going to take note of any masses, nodules, anything that you would feel in the abdominal cavity. Next, you're going to go on and palpate actual specific organs and structures within the abdomen. So first, you're going to be doing the aorta. So that should be just left of midline here, and you should be able to kind of feel the pulsation of the aorta when you place your hand right here. And then you can also kind of palpate the size if you want to. Periumbilical area and the umbilicus. So looking for any tenderness or any pain, anything listed by the patient, any grimace by the patient, and then also the actual umbilicus itself. The bladder, you can palpate in the hypogastric area, however, it's not going to be palpable in a normal individual. If they came in with bladder complaints, something wrong there, then maybe you'd be able to palpate it. After that, you're going to go on and you're going to actually palpate the liver. So easy way to do this, you can do the hook method, where you actually hook around the costal margin, or you palpate up as the patient. Go ahead and breathe in for me. Okay? And then you go ahead and say, go ahead and take a deep breath, or breathe everything out. And then as you breathe out, try and hook your fingers underneath that costal margin, feeling for the edge of the liver. Okay? Or you can do it with a one-handed up into the liver area as well. While you're over here too, you can do ballottement to try and palpate the kidneys. So your non-dominant hand underneath the patient, and you just kind of push up. And with the other hand, you're pushing down to try and feel the pole of the kidney. It's pretty difficult, and you're probably not going to be able to feel anything. Okay? Same thing on the other side. Up underneath the patient, and then palpating, trying to hit that pole of the kidney. Okay? And lastly, you're going to do the spleen and gallbladder on the patient's left side. So go ahead and take another breath in for me. Everything in the abdomen moves down. Go ahead and breathe out. And you should, if they have a, let's say, splenomegaly, you'll be able to feel the spleen past the costal margin. And then lastly, you're not going to be able to palpate it because in a normal, healthy patient, you're not going to be able to feel it. But here's the midline. This would be the line. Midclavicular line right here. Kind of in between that is where your gallbladder would be if you could feel it. Okay? And nothing. Okay? So that's your palpation. Now you're going to move on to doing your special tests. So we're going to start with the Blumberg and the McBurney's. Okay? So Blumberg is rebound tenderness in the quadrants. Okay? It could be a sign of peritonitis, or it could be a sign of appendicitis with radiation. So all you do is you push down, release. Any pain with that? Any pain with that? Any pain? And then you can do the lower right quadrant, but then the important area would be the McBurney's, which is you find the iliac crest here, You go in about an inch, or so, and you push down. Any pain with that rebound? Okay, good. And that's your Bloomberg and McBurney's. Next is going to be assessing for Cullen's sign as well as Gray Turner's. So you're looking for any ecchymosis around the umbilicus and any ecchymosis at the flanks. This is more of an observation than it is actually a palpation or placing your hand on the patient. After that, you're going to ask them if they have any pain radiating from their abdomen to their left shoulder, and that's going to be Kerr's sign. So do you have any pain radiating to your left shoulder from your abdomen?
No.
Okay, so negative Kerr's. After that would be Markle's. So you come over here. Go ahead and lay your knees down for me. And that's simply the heel tap test. So with the patient laying down, go ahead and tap their heel. Any pain with that? And then you can also do it on the other leg. The other way you can do this is have the patient stand, raise up, and then come down onto their heels. If that elicits pain, that's a positive Markle's. Next would be Murphy's. So on inspiration, you palpate the gallbladder, and if the patient has any cessation of that respiration on inspiration, holy crap, that could be a possible cholecystitis. So go ahead and take a deep breath in. You palpate in the area of the gallbladder. Obviously, the patient didn't stop breathing. No pain was elicited, so that's negative Murphy's. After that, you're going to do Rosvig's, Rovsing, and that is lower left quadrant rebound tenderness that then radiates over to lower right quadrant rebound tenderness. Okay, and that could be peritonitis, or it could also be appendicitis. So go ahead and do this. Any pain with that?
No.
Okay, good. And the last one, or last two, I should say, would be your iliopsoas and your obturator. So you go ahead and have the patient lay their right leg out, and there's a muscle that spans from their lower extremity up past and over the appendix. So you go ahead and say, can you lift your right leg for me? Any pain elicited with that? Okay, good. So that's negative iliopsoas. And then lastly, the obturator. You go ahead and take and put the knee 90-degree flexion, the hip in a 90-degree flexion. You can go and lay that knee down for me. And you just manipulate the knee around at the hip. And then you bring it in. You can even push down a little bit. Any pain elicited in this area? Okay, good. So, and that's testing for any sort of obturator hernia or appendicitis as well. We already did ballottement when we were palpating the kidneys. So you can just say I already palpated, or I already did the ballottement test with assessing the kidneys when I was palpating those. And that should actually conclude the abdominal examination. The next part of it, do you want to pause it?
Okay.